we start from today's lecture. This is the next page from where we left, and there are some diseases like other demyelinating and dysmyelinating disorders. Osmotic demyelination syndrome, also called central pontine myelinolysis. So, myelinolysis is the condition in which the myelin sheath is destroyed. Massive axonal demyelination in pontine white matter. This is the pontine area, and here is the light area which is showing demyelination, which is secondary to rapid osmotic changes, most commonly iatrogenic correction of hyponatremia, but also rapid shift of other osmolytes, e.g. glucose. Acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness can cause locked-in syndrome. So, it results in acute paralysis, dysarthria, dysphagia, diplopia, and loss of consciousness. Correcting serum sodium too fast. From low to high, your bones will die. Osmotic demyelination syndrome. From high to low, your brains will blow. From low to high, your bones will die. Osmotic demyelination syndrome. From high to low, your brain will blow. Cerebral edema, herniation, osmotic demyelination. Acute inflammatory demyelinating polyneuropathy. Most common subtype of Guillain-Barré syndrome. Acute inflammatory demyelinating polyneuropathy. Autoimmune condition that destroys Schwann cells via inflammation and demyelination of motor fibers, sensory fibers, peripheral nerves including cranial nerve 3 to 12. So it destroys the Schwann cells by inflammation and demyelination of motor fibers, sensory fibers, peripheral nerves, including these cranial nerves 3 to 12. Likely facilitated by molecular mimicry and triggered by inoculation or stress. Despite association with infections e.g. Campylobacter jejuni, virus e.g. Zika, no definitive causal link to any pathogen. So despite association with the infection, for example Campylobacter, so these two organisms are the causative agents. First one is Campylobacter jejuni and the virus, that is Zika virus. No definitive causal link to any pathogen. Results in symmetric ascending muscle weakness. There is symmetric ascending paralysis and depressed absent DTR, deep tendon reflex, are absent beginning in lower extremities. Facial paralysis usually bilateral. There is also facial paralysis. These are the Symptoms: facial paralysis, usually bilateral, respiratory failure are common. May see autonomic dysregulation, cardiac irregularities, hypertension, hypotension, or sensory abnormalities. Most patients survive with good functional recovery. So we diagnose it by having increased CSF proteins with normal cell count, albuminocytologic dissociation. Respiratory support is critical until recovery. Disease modifying treatment. So the treatment mainly surrounds the respiratory support. Disease modifying treatment require plasma exchange or IV immunoglobulins. No role for steroids. So as the name indicate, it is acute inflammatory demyelinating polyneuropathy. So we see Guillain-Barré is an acute syndrome. It destroys the Schwann cells which are involved in myelination, so it is a demyelinating disorder. Schwann cells are destroyed by inflammation and demyelination, so it is also an inflammatory category. And polyneuropathy is because it demyelinates the motor fibers, sensory fibers, peripheral nerves, which includes cranial nerve 3 to 12. Two infective agents are involved, Campylobacter jejuni and viruses. We have symptoms of symmetric ascending paralysis. So we have these symptoms. For diagnosis, there would be increased CSF protein with normal cell count and dissociation. Treatment includes respiratory support, modifying disease modifying treatment such as plasma exchange or IV immunoglobulins. No role for steroids. There is now the other one is acute disseminated post-infectious encephalomyelitis. It is acute and disseminated means focal inflammation and demyelination after infection or vaccination may present with rapid progressive multifocal neurologic symptoms, altered mental status. So it is post-infectious. So as written in the text, it is multifocal and disseminated mean multifocals having multifocals. Post-infectious as shown, inflammation and demyelination occurs after infection or vaccination, and it presents with multifocal neurologic symptoms as the name indicates encephalopathies. So the other thing is Charcot-Marie-Tooth disease, also called hereditary motor and neuron disease. It is a rare disease. It is caused by mutations in the gene called MECP2. It is inherited autosomal. It is autosomal dominant. It is autosomal recessive. It is autosomal recessive and sensory neuropathy, group of progressive hereditary nerves disorder related to defective production of proteins involved in the structure and function of peripheral nerves or myelin sheath. It is typically autosomal dominant and associated with foot deformities. Deformities we have in the foot would be pes cavus or hammer toe, lower extremity weakness, foot drop, and sensory deficit. We can't move toes. Most common type is CMTIA, caused by PMP22 gene duplication. So, in this disease, we have symptoms more common related to our foot deformities, just like Pascavus and hammer toe, lower extremity weakness, foot drop, and sensory deficit. Progressive multifocal leukoencephalopathy. It is again demyelination of CNS due to destruction of oligodendrocytes. As oligodendrocytes are involved in the myelination in CNS, it is secondary to reactivation of latent JC virus infection. It is associated with severe immunosuppression, lymphomas and leukemias, AIDS, organ transplantation. Rapidly progressive, usually fatal, predominantly involve parietal and occipital areas. Visual symptoms are common, increased risk associated with natalizumab. So it is a demyelination disorder, progressive multifocal leukoencephalopathy due to destruction of oligodendrocytes, secondary to reactivation of latent JC virus infection, associated with severe immunosuppression, which are the result of lymphomas, leukemias. AIDS is also an immunosuppressive disease, or organ transplantation is also an immunosuppressive condition. It is rapidly progressive, as the name indicates, and usually fatal, predominantly involve parietal and occipital areas. Visual symptoms are common. So, visual symptoms. This is the area which is involved, occipital and the parietal. So, other disorders are Krabbe's disease, metachromatic leukodystrophy, and adrenoleukodystrophy. So, now there are some neurocutaneous disorders. Sturge-Weber syndrome. It is a genetic disease and it is congenital, non-hereditary anomaly of neural crust derivatives. So the problem is in the neural crust. Somatic mosaicism of an activating mutation in one copy of GNAQ gene. So the presentation is in the capillary vascular malformation. Port wine stain is in the picture A. So this is the port wine stain. Oh my god. Yes, the port wine stain. Nevus flammus, flammeus, or non-neoplastic birthmark, which involves the territory of cranial nerve 5, first and second branch distribution, ipsilateral leptomeningeal angiomas with calcifications. So there is also ipsilateral leptomeningeal angiomas with calcification, seizures, epilepsy, intellectual disability, episcleral hemangiomas. This is also the visual symptom, and increase intraocular pressure, early onset glaucoma. It is also called encephalotrigeminal angiomatosis. Sturgeon-Weber syndrome is also called encephalotrigeminal angiomatosis, as it involves the meninges, so encephalo, and the trigeminal nerve branch 1 and 2, so encephalotrigeminal angiomatosis, as it causes angioma in the meninges and hemangioma in the episclera. So the next is tuberous sclerosis, AD, Alzheimer's disease, variable expression mutation in the tumor suppressor gene TSCI1 on chromosome 9, hamartin. So the tumor suppressor gene C2 on chromosome 16. These are the two genes which are involved, tumor suppressor gene C1 and tumor suppressor gene C2 on chromosome 9 and 16 respectively. So these named tuberin, pronounced tuberin, hematomas in CNS and skin, angiofibromas, mitral regurgitation, leaf spots, cardiac rhabdomyoma, intellectual disability, renal angiomyolipoma, Shagreen patches. It increases incidence of subependymal giant cell astrocytomas and ungual fibromas. So it forms ungual fibromas, astrocytomas, and subependymal giant cell astrocytomas. Neurofibromatosis type 1, autosomal dominant. It is also autosomal dominant. Sorry for Alzheimer's disease. It is 100% penetrance. It has 100% penetrance. Mutation in neurofibroma gene 1, which is on chromosome 17. So there are cafe ole spots. There is intellectual disability. What are cafe ole spots? Let's see in the picture F. These are the cafe ole spots. Cutaneous neurofibromatosis in picture G. Yes, this is the neurofibromas. And leash nodules, pigmented iris hematomas in the picture H. So these are the iris hematomas, optic gliomas, pheochromocytomas, seizures, and focal neurologic signs, often from meningiomas, bone lesions, e.g., sphenoid dysplasia. So, C for caffeole spot, I for intellectual disability, again C for cutaneous neurofibromas, L for leash nodules, O for optic gliomas, P for fuchromocytomas, S for seizures, and S for focal neurologic signs. It is also called von Recklinghausen disease. So there are 7 letters in von Recklinghausen, so the chromosome is 17, just for mnemonic. Neurofibromatosis type 2. It is also autosomal dominant mutation in neurofibroma 2 tumor suppressor gene myelin on chromosome 22. There are bilateral vestibular schwannomas, juvenile cataract, meningiomas, and ependymomas. Neurofibromatosis 2 affects 2 ears and 2 eyes. Ears as it involves vestibules, and 2 eyes as it involves juvenile cataract. Von Hippel-Lindau disease. It is also autosomal dominant deletion of von Hippel-Lindau gene on chromosome 3p, VPHL gene. Ubiquitinates hypoxia inducible factor 1A. These are hemangioblastomas, high vascularity with hyperchromatic nuclei in retina, brainstem, cerebellum, spine J, angiomatosis, bilateral renal cell carcinomas, pheochromocytomas. So it forms hemangioblastomas, high vascularity with hyperchromatic nuclei in retina, brainstem, cerebellum, spine, angiomatosis, bilateral renal cell carcinomas, and pheochromocytomas. So what are hyperchromatic nuclei? As in the picture I, which are staining these red, these are hyperchromatic, which are picking more color on the stain, so hyperchromatic. So in retina, brainstem, cerebellum, and spine. In spine, these are the hemangioblastomas. Yes, these and these. Numerous tumors, benign and malignant, HARP, VHL, 3 letters, chromosome 3 associated with RCC, also 3 letters. ARP, HARP, HARP, hemangioblastomas, angiomatosis, renal cell carcinomas, and pheochromocytomas. So VHL has 3 letters and it is on chromosome 3. It is associated with RCC, which also has 3 letters. So these are the adult primary brain tumors, glioblastomas. So it is a grade 4 astrocytoma, very common, highly malignant, and primary brain tumor with approximately 1 year median survival. Found in the cerebellar hemisphere, can cross corpus callosum, butterfly gliomas associated with EGFR amplification. Histology astrocyte origin GFAP positive, and it is pseudo palisading pleomorphic tumor cell. Border central areas of necrosis, hemorrhage, and or microvascular proliferation. It is oligodendroglioma, relatively rare, slow growing, most often in frontal lobe, often calcified. Oligodendrocytes origin fried egg cell, round nuclei with clear cytoplasm. It has a chicken wire capillary pattern. Picture D belongs to it, so let us see picture D. Picture D. So this is picture D. Wire D. Chicken wire. What is chicken wire? Chicken wire capillary pattern. It is relatively rare, slow growing, most often in the frontal lobe, often calcified, as in picture C. So let us see picture C. Yes, this is involving the frontal lobe. Fried egg cells, as it is shown in the picture. These look like an egg which is fried, and this yellow or purple colored is showing the yolk. Meningiomas, typically benign. Females are most commonly involved. Occurs along the surface of brain and spinal cord, extraaxial, external to brain parenchyma. May have dural attachment tail. Often asymptomatic, may present with seizures or focal neurologic signs, resection and or neurosurgery. It is arachnoid cell origin, spindle cells concentrically arranged in a whorled pattern, semoma bodies, laminated calcifications in arrow F. F picture laminated calcifications. Hemangioblastoma, often cerebellar, associated with von Hippel-Lindau disease, as we have discussed previously. It has HARP, pneumonic hemangioblastoma, and angiomatosis, bilateral renal cell carcinoma, and pheochromocytoma. So hemangioma, it is cerebellar, often involve von Hippel-Lindau syndrome when found with the retinal angiomas, can produce erythropoietin and is secondary to polycythemias. Blood vessel origin, closely deranged, thin-walled capillaries with minimal intervening parenchyma. There is pituitary adenoma, may be non-functioning, silent or hyper-functioning, hormone producing. Non-functional tumors present with mass effect, e.g. bitemporal hemianopia, due to pressure on optic chiasm. Pituitary apoplexy, hypopituitarism. Prolactinoma, classically present with galactorrhea, amenorrhea, decreased bone density due to suppression of estrogen in the females, and decreased libido, infertility in males. Treatment is dopamine agonist like bromocriptine and cabergoline. Transsphenoidal resection is also the treatment of choice when it is refractory to medication. There is hyperplasia of one type of endocrine cells found in the pituitary, most commonly form lactophores in the and forming the prolactinoma. This results in hypoprolactinemia, less commonly from the somatotrophs GH, acromegaly, gigantism, corticophores ACTH, Cushing disease, and rarely from the thyrotrophs TSH, gonadotrophin, FSH, LH. So the next is schwannoma. It is classically at cerebellopontine angle. Benign, involves cranial nerve 5, 7 and 8, but can be along any peripheral nerve, often localized to cranial nerve 8 in the internal acoustic meatus. Vestibular schwannomas can present as hearing loss and tinnitus. Bilateral vestibular schwannomas found in the neurofibromatosis type 2, resection or stereotactic radiosurgery. Schwann cell origin S300 is the tumor marker, biphasic, dense, hypercellular area containing spindle cells, alternating with hypocellular and myxoid areas.